Three, two, one. Good evening. This is John Bennett from Miami, Florida. Robotics Weekly broadcast. Tonight we have Brian Smith from Virginia. He's a general surgeon that uses robotics quite frequently, and he's going to speak of his experiences being an overseer of other surgeons learning robotics, as well as a couple other topics. So, good evening, Brian, and welcome.
Hi, thanks, John. Thanks for having me on tonight. Excited to do this with you.
Okay, Brian, I guess I know that robotics is popular in general in urology. You see it everywhere in the net. So could you briefly talk about the areas of surgery that the robotic impacts, please?
Sure. Well, it's spreading. It definitely started with urology. They were probably the first group to really pick it up. The early technology, the early versions of it were especially suited for one targeting one area, such as the prostate. And since then, we've had development, better machines, and new graspers and equipment, and it's sort of spread then from urology to thoracic surgery, cardiac surgery, general surgery, and GYN, both benign and for malignant disease. And the it's about 80%, I think, currently is the usage rate of robotics for urology for prostatectomy, and GYN now is behind that, but is catching up, and then general surgery is probably just at the beginning of the curve as far as for picking up the technology and using the technology. But looking at the curves, is kind of following the same basic pattern as what the others did, and so I think we're going to see a growth in its applications for general surgery, especially as they continue to kind of focus on that and make more instruments and more useful equipment, basically, for the technology, for the techniques that we use.
Well, how were you first exposed to robotics? In your training, or when exactly did you first see it?
So I was exposed to an earlier version of the Davinci equipment as a resident, and we were using it mostly for it was the urologists who were using it mostly, plus we were doing some training with it. And then as a general surgeon, it was being used really by the people doing the gastric bypass. So because that requires a lot of suturing, intraoperative suturing, and it's much easier to suture with the robot than it is laparoscopically by hand with the straight instruments. And so they were the first ones to kind of pick it up. And then so that was my introduction with it. Then I didn't really use it for a while. I became interested in some of the single incision type laparoscopic surgery, but it's pretty difficult, except for maybe with the exception of one or two procedures. But the robotic devices came along that made it much easier, and it was at that point that I got interested and started training on robotics.
So you would say the learning curve for robotics is not as steep as laparoscopic?
No, it's definitely not. The procedure is basically the same. So as long as you have training in the procedure, that can be applied. And then the rest of it is just really figuring out port placement and spacing of the robotic arms, and then which instrument to use. It's a little bit different, and it takes some getting used to, but it's for people who are a decent amount of laparoscopic experience. It's a pretty quick. They're pretty quick to pick it up usually.
Okay, that's. But what types of surgery, like in general surgery, because you're a general surgeon,
mm-hmm.
What are the surgical procedures that you use it for mostly?
So I use it for single incision cholecystectomies, for gallbladder removal. I also use multiport. I use it for paraesophageal hernia repairs because it's again, there's quite a bit of suturing in that, and it's a lot faster and more precise. I can do it much more quickly, even with having to place the arms and dock the arms and whatnot. We also use it for some colon surgery because there's some special things that you can do with the robot that you can't do with laparoscopic surgery, at least not yet. And then there's we also use it for things like treatment for achalasia and those kind of procedures.
I noted you didn't say appendectomy. Is it not used very much in appendectomies?
No, not really. It's there's some cost associated with using the robot, and the, the appendectomy is a pretty straightforward procedure, and it seems like it would be a little bit unnecessary.
Oh, okay. 'Cause that kind of negates the time saving. You really don't need to save too much time in a regular, uncomplicated appendectomy.
Right.
I'm surprised when you say that it saves time. You can suture quicker with robotics. That's surprising. Is it the layer closure? Because I don't have a lot of experience in general surgery, but I know that every time the surgeon goes to the belly, there's layers. There's like 4 or 5 layers, correct? And you've got to close the layers going in and coming out. You got to sew them up. So I guess you save a lot of time in that layer closure.
Well, that would be more for open surgery versus the laparoscopic. So if we're looking at it, would be more of a comparison of laparoscopic to robotic in this. So they're both going to use ports where most of the ports don't have to be closed except for at the skin, except for the very large ones. But the suturing that I'm talking about is like the inside, the actual suturing for the repair. So when you're closing the hiatal hernia, when you're doing the fundoplication, when you're sewing the stomach to the stomach and actually making the rat. It's the sutures there that are much quicker because you can tie easily. You have wrists, you have dexterity. You can zoom in quite a bit. You can see so much better. Place the sutures exactly where you want. More likely to get good tissue bites and things like that. So it's the actual steps of the procedure that I can do a lot faster with the robot than I can do with traditional laparoscopic equipment.
I was surprised when one urologist was speaking about. I asked him about bleeders, getting those darn bleeders, which is also always a concern of a surgeon. And he says that you can see so well into the field that you can see the bleeders a lot better than you could just with a regular eye.
Sure. Oh yeah. You almost, there's 2 things. So you can almost do most of it with blood dissection and things like that. You can almost do a bloodless operation where there's almost, I'm talking like 2 or 3 cc's of blood loss for a procedure. And then the other thing too is you have to, sometimes you see so well that it fools you. You see this little tiny thing that's bleeding, and it starts to make me a little nervous. And then I realize that it's so tiny I can't even put a clip on it. It's just,
Really, that's small.
And it's, it's about 2 cells thick or something like that. You can see it. And so you have to kind of keep that in mind, that the vision is so good, but sometimes you're seeing a little more than you want.
At the particular hospital you work at, is it pretty well accepted by the general surgery department?
Well, it's kind of new, so it's yes and no. There's some people that I think aren't as interested in picking it up, and then there are people who are more interested in it, like myself, and it's somewhere in between. I think it's probably going to be that way for a while. And there's a lot of people that they say, well, I can do it laparoscopically just fine, and so I don't need it, and that's probably a good argument. But for some things, and then you have to weigh in the cost. I think we've kind of looked at that quite a bit, and for some of the procedures, the most expensive thing is going to be time in the operating room, and then potential complications and return to the hospital, things like that. So anything you can do that'll decrease that is really going to be where there's big savings. And so we'll sort of have to see how this plays out down the road. But there is quite a bit of debate right now in the general surgery community about its usefulness.
Yeah, and obviously it's the younger people that probably accept it on a lot higher percentage than the older surgeon, correct?
I think that's probably true.
Yeah, I guess it's like that with lots of technology. So, okay, I think I've covered some of the basic points that I wanted to cover. So, take it away as far as your presentation.
Okay, great.
And just let me know if you're having a hard time with any of your stuff.
Okay.
Sometimes I have a hard time opening the menu bar sometimes. Okay, there we go. Okay, I'll tell you what's going on. I'll tell you exactly what I see to make sure that...
You can see it now in the PowerPoint?
Yeah, I can see it. Excellent. Yeah, excellent picture.
Okay, great. So this will just cover some of the uses of robotics for for general surgery and single site robotics, and then there really is kind of a focus on the training pathway for people who are interested in it. So I'm a surgeon with Surgical Associates of Richmond. We cover a few hospitals. The one that I operate primarily out of is Chippenham Medical Center, part of CJW Medical Center here in Richmond, Virginia. We sort of started the robotics program there. They had one in the past and got rid of it and then brought it back a few years ago. And so I was part of one of the surgeons who started it. And I'm currently the chairman of the steering committee for the robotics program there at Chippenham. So this is just a picture for people who haven't seen it. This is the Davinci Si system. It has, can you see my cursor if I point with it? Or no?
Let me see here. Can you move it around a little bit more? No, I cannot, unfortunately. Can you see it?
Well, I can see it, but I don't know if anyone else.
Well, yeah, I can.
Okay.
Well, tell me what to point to, and I'll point to it.
No, it's okay. It's just I was going to show there's that shows there's three arms plus a camera arm. So you have so there's a camera that the surgeon controls, and then there's a right and a left operating arm, and then there's a third arm which can be a retracting arm or an operating arm. So there's a lot of flexibility in the system, and that third arm can be put on the left or the right side of the patient depending on how you're doing the procedure. So this term, the robotic surgery, is not exactly, it's a bit of a misnomer. It's actually, a robot is really a machine that can carry out a set of actions that's been programmed by a computer. And that's not what this does. That would be, there was, when this first came out, there was some backlash because people thought that maybe these things would be operating independently. There would be some room for malfunction and issues like that, but it's just an interface between the surgeon sitting in a console and the robotic arms, and so the arms don't do anything that the surgeon at the console doesn't tell it.
Excuse me, Brian, your first slide is still on. You want the first slide on, or are you on the second slide?
Oh no, second slide.
Okay, it's not showing apparently. Can you adjust it at all, or is there anything you can do? Are you seeing the second slide or the first?
I'm seeing the second. How about that? Do you see it now?
No, I'm still not seeing it. And what I see is being recorded. So, but what can we do here? Oh, there we go. Okay, yes, I can see it now. Okay. And I'll let you know what slide's on. Okay. You got the robotic arms there now.
Okay. How about if I do this? Now, do you see it now, the second slide now?
Yeah, I can see the second slide now. It has robotic arms, correct?
That's right. Okay, so that shows the three arms plus the camera. Okay,
right.
So now do you see the next one?
Okay, not yet.
Okay.
Not yet. Not yet. Still the same slide. Okay, there we go.
Okay, I'll just do it like this. I mean, can you read it like that, I guess?
Yeah.
All right.
I can see your cursor now too.
Okay, I'll just zoom in this way. So okay. Well, anyway, so again, it's so at our hospital we did some single incision surgery, did some colon procedures, so sigmoidectomies for mostly for diverticular disease, and also laparoscopic appendectomies and cholecystectomies. And this was before the technology was available on the Davinci Si. So we were doing mostly lap choles, but the problem, it's difficult. So what you do in that case is you take all the instruments, all the laparoscopic instruments, and you put them straight through one port, which is usually at the umbilicus at the patient's belly button. And that is difficult because it decreases the triangulation that helps you to kind of figure out the 3D environment you're working in. So you don't have you're looking with the instruments right down the shaft of the instrument because it's up against the camera, and then as you're moving the instruments, you're pushing against the camera. It's pretty difficult. You're also crossed, so your left hand is crossed, and you're leaning over, and your right hand is working where your left hand looks like it ought to be on the camera. And it's a pretty difficult procedure done that way. Then we launched the robotics program, and so we had again gynecology, urology, thoracic and cardiac surgery, and then general and colorectal surgery all started at the same time, basically. And so the way that we did it was with this clinical pathway. And this is the basis to starting any kind of a robotic program. So if you watch videos, there's actually quite a bit online, a few websites, and also Intuitive, who's they're the company with Davinci. They have quite a bit on their website. Their website's actually gotten even better than when we started it. And then we also did simulation. So I think you had Mimic Technologies on, and so that's one of the companies that does this. And there's depending on the hospital, there's a set time, a certain number of procedures you have to do. Training hours that you have to put in before you can proceed with moving ahead with actual training in the lab. So the next step then after that is case observation, which means going somewhere to see a surgeon who's doing robotic surgery, or the type that you'll be doing. So going and seeing, for me, a general surgeon performing procedures. If you were a colorectal surgeon or a GYN doc, would be to go see someone who's pretty familiar with the procedures. And those people are people who have been approved or chosen by Intuitive to do that. So it's people who are kind of doing best practices and are familiar with the procedures. After that's done, then go off to off-site training. Currently, there are a number of different off-site training sites. I think they're trying to bring it all together at one place, but they're not quite there yet. But this is where you go and you have a animal lab, and you actually sit down at the console and do some operating. So they take you through a set of tasks, and then once you complete that, then you can do some extra things that are a little bit more focused for what you're actually going to be doing with the robot. It's good in that case if you have somebody that you know you're going to be working with, a surgical assistant, a first assistant, to bring that person with you so that both people can be trained at the same time, so they can learn, instrument exchanges and port placement and all those things become really important and are really the basis for how the procedure is going to proceed once you start. Then you have to have team training. If it's a new program like ours was, starting from the beginning, so everyone had to kind of learn at the same time. So you have the circulators and the scrub techs, and everyone needs to be brought up to speed on how to carry out a robotic procedure. It's quite a bit different as far as the setup and having equipment than in regular, say, laparoscopic cases. And then finally, after that's all done, then you have to do then you schedule your cases, hopefully shortly after the training, so that you can do your off-site training, and then while it's still fresh in your mind and the procedures are still, the moves, the docking, the robot, and things like that, still fresh in your mind, and then you go on to practice cases. And the number varies. It's usually somewhere 4 or 5 cases where you perform the surgery, but there has to be a proctor who's there, someone who is very familiar with both the procedure, both laparoscopically and robotically, and is there and can kind of help you, give you tips and make sure that it goes smoothly. So the idea is really to start with multi-port cases, so again, it's the training and observation, which is important at the beginning, and you really need to focus then on the time. So one of the things that makes it back in the day, there was some pushback because the operating times were quite long with robotic procedures, and some of them still are. But if you're doing some of the cases like a gallbladder procedure, for example, it should be pretty short. And so if you start if you start with shorter cases and you can wrap those cases up quickly, then that sort of sets expectations for the hospital and for the team of how you're going to how long it's going to take to do your procedures. The biggest thing that controls that, how quickly you can do those procedures early on, probably, is docking and port placement. So you need to practice the docking quite a bit. When I say docking, what that means is taking the port. So once the port is placed in the patient, taking that port and then docking it, so attaching it to the robotic arms. And it looks easy when you see someone do it, but when you're first learning to do it, it's actually pretty difficult. And then when you have other people standing around watching you do it, it makes it a little more difficult. So that's the first thing to really pick up. And that's where you can really drop a lot of time off of the time of the procedures just by learning to dock quickly. The other one, the really important one, is port placement. Makes or breaks these procedures. You have to have a certain distance, at least 10 centimeters if you can, from port to port, to really keep the arms separate so that you can use the arms. And the whole idea of it is to be able to see better and to be able to use these arms. And so if you put the ports in the wrong place and you can't really use the arms, then you've kind of defeated the whole purpose of using the Davinci system. So you have to look at port placement. It's a little different on each patient. They have some guides, but that comes from talking to people, doing case observations, and then talking to your proctor and seeing what's the best thing. The other thing is that the importance of team. In this case, it's extraordinarily important. So you have to make sure that you have a really well-trained team there, because again, the surgeon at this point, now that the ports are in and the thing is docked, goes and sits down. And so all of the instrument exchanges, all the equipment exchanges, all of this, there's an assistant port, all of that has to be controlled by the team. So the team really has to know what's going on, has to understand the flow of both the procedure and the robotic cases in general, and then also has to be on board with it. So you don't want people who don't want to be there. It has to be people who are interested in learning it, interested in going forward with robotic surgery. And then the final thing is that unlike a lot of other procedures, larger patients, heavier patients are probably easier for beginners. You need to have the arms as widely spaced as you possibly can when you're first learning to do this. And so the tendency for surgeons is to think that smaller, low BMI, very thin patients would be the easiest patients, and it's actually not the case in this with robotic surgery. It's really the opposite, which is a little different. So when we started our multi-port experience, we did cholecystectomies and then did large periesophageal hernia repair, giant hiatal hernia repair, colectomies, low anterior resections, gastrectomies, hilar myotomies, and some GI stromal tumor resections. And then we went ahead. The purpose, one of the things that drew me to this was really the single-site surgery application for the robotic surgery. And so the pathway for that is again, it kind of repeats the pathway for learning robotic surgery in general. So the suggestion is somewhere between 10 and 20 multi-port cases. At the time that we did it, we were one of the first centers to start with single-site, and so it was there was quite a bit of scrutiny on our program, and making sure that we were really dedicated to it and interested and focused. I think now there's not quite as much focus on it, but the principles are the same. So you need to be able to you have to be familiar with the procedure, docking, familiar with the instruments, and just the stepwise exchange of instruments. And then there's online training modules which take you through the equipment, because the equipment changes when you go from single site to multi-port. From multi-port to single port. And then when that's finished, again, there's some off-site training with an assistant, so you go back into the lab and bring your assistant along. Some advantages for the Davinci single-site surgery platform versus the just plain laparoscopic single-site. Again, versus multi-port. So the docking is easy. It's easy to, there's one incision instead of 3 or 4. There's no there's no choosing where to put the ports. You just put one port in basically, and then the rest of it, the cannulas go into the port. I'll show you that. Okay. And so there's really not. They've actually eliminated some of the difficult part of robotic surgery by just making it one location. When we were tracking our first maybe 25 cases or so, I was tracking the time. So it's another thing I recommend to people because it helps when you start to really look at your numbers. You can track it and see it drop as you get more familiar with the equipment. And if it doesn't drop, then you can see what happened in that case. You can figure out what happened with that particular procedure. Our case time was during our learning curve was about 23 minutes of consult time. So that's actual operating time for the surgeon sitting in the console doing the procedure, and then about 45 minutes for skin to skin for the procedure itself. And we had good outcomes and patient satisfaction with that. So here's what this is. So this is the single port. So it's a little silicone port here, and it has it doesn't show up on here, but it has multiple little holes through it here. So you can there's a camera cannula here, then there's an assistant cannula, and then these two curved operating cannulas. And so this is the left and the right arm. This is an assistant port where the assistant can go in with a regular laparoscopic equipment for manual retraction. And then this is where the camera goes, and this little thing is where it attaches to an insufflator. So this is where it blows gas in it. So you need about a 2.5 centimeter incision to place this soft port, and then you can proceed from there. So this shows it. This shows the robot has been moved in, and then it's docked. So this is when I say docked, this is what I mean. So you can see where the arms are actually attached to the cannula. So here's the right and left operating cannula. Got the assistant port in here, and then the camera cannula here. And once these are set in, then the instrument slides down in through here. It attaches up here and slides in through here, and then you can operate with it. Any questions so far?
Yeah, just a couple, Brian. We have one from an actual tweeter.
Mm-hmm.
And hopefully, I don't know, you may have covered this or not. You say that the surgeon has to operate a certain amount of hours on a procedure before he's kind of let go and does it on his own. How many hours would that typically take, say, with a cholecystectomy? Do you have a certain amount of hours that he has to do that monitor before he can be unleashed?
So the way they do it really is it's a certain amount of hours on the trainer, something like the Mimic trainer, the Davinci trainer, just prior to beginning to do robotic surgery in general. So it's not for each particular procedure. It's just for the robotic surgery in general. It depends on really each hospital system. Currently, each hospital system can kind of set its own rules for that.
Okay.
And so I think it's usually somewhere around, I think it's around 20 hours or so. And what that is, you can go through different modules, and the modules again start with, it's mostly technique as far as using the arms, so clutching, moving the arms around, moving the camera around, zooming in, picking up things, setting them down, tying, those kind of things. And so it's more basic stuff. It's not so much going through the procedure. Because the idea is that hopefully the procedure, the steps of the procedure you already understand pretty clearly, and it really it should just you should just be able to duplicate that in the robotic setting.
Does the hospital monitor the hours, or does the Department of Surgery monitor the hours, or is it up to the surgeon?
It's probably all three. I mean, it's part of the credentialing. So you have to be credentialed to do robotic surgery, and so it's part of the credentialing guideline. But it's kind of up to the surgeon and also intuitive. So you can't really begin to do the procedures until you've gone through your required training.
Okay. Very good.
Okay. So this shows you here's a side view. So again, remember when I was talking about the single site with the regular laparoscopic equipment, it bangs against each other. But the way that this gets around that is that these are curved and they're in a different plane. So the camera sits up here, and then the curved arms sit below. And so the camera is completely separate and operates separately from the arms. And you don't get the banging. You don't get when you try to move this arm, it doesn't push this arm out of the way. The one thing right now, the current single-site robotic equipment. At this point, though, because it has to go through these curved cannulas, it doesn't have the wrists. So that's one of the huge benefits to the robotic surgery, is having the wrist. It reproduces open surgery, basically. That's what makes suturing easy, and just having the extra dexterity. And then about the time that you get used to that, after about 10 or 20 cases, and then you switch over to single site, then they take the wrists away. So you have to adjust to that. So that's kind of where we are. Hopefully the next version that comes out will have wrists on the single site instruments. And then I think the single site will be more useful, more broadly applicable at that point. It's really only at this point for cholecystectomy and hysterectomy, although people have been using it for other procedures like colectomies and whatnot. The one really amazing thing about this, again, with laparoscopic equipment, you're operating mostly with your hands crossed for single incision, and for this, the robot does it for itself. So you just tap a pedal and it switches left to right. And so what you're operating with, so these are the little finger controls. So when you're sitting at the console, your fingers would go in here and here, and here and here, and this controls the tip of the instrument. Open, close, right, left, and things like that. And so what it does is, even though this technically would control this arm, you hit a button and it switches it so that since the instruments are crossed, what looks like is your left hand is controlled by your left hand, which is really nice. You don't have to do that thinking for yourself. It's a huge benefit to this setup. So it's an 8.5 millimeter scope. It's slightly smaller than what you would use in a multiport, which would be a 10 millimeter scope. They say that it's a little bit darker, but I have a really hard time telling. I really can't tell the difference between the two. And then the instruments slide down into the arms, like I said, are curved, and then come across there. So it's a single port. If for some reason you ran into a case where it's a bad case of acute cholecystitis or something where you couldn't lift it up with these, you couldn't just do it with just these instruments, and the assistant is cool. You can always bring in a third arm, and so that third arm, then you could put in an extra cannula somewhere, so then you'd have two incisions, and that one would have wrists, and so you would have stronger, bigger instruments and things like that you could do. So it's a very flexible system. Here's a intraoperative photo, and you can see this is what it looks like here. So this is the patient's abdomen, and here the port is in place. Here it is after. You can't even really see where the port is placed. And then here's one of the patient's post-op, and so there's instead of the usual incision here, 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 and here, there's just a hidden incision here. So again, the benefits versus straight stick or straight laparoscopic single incision surgery was that there's no clashing. The visualization is better. The camera's away. The visibility is not compromised. Angles are excellent for clip placement. The ergonomics with the left-right switch. And then there's a wider applicability, so you can do larger patients. You can do patients with acute cholecystitis, things that you couldn't get away with, you wouldn't be able to do with straight laparoscopic surgery. I'm sorry, with straight laparoscopic instruments with single incision surgery. Here's a view from single incision. I'm not going to try to play the video, but basically, if you're looking straight down the site, and so if the instruments move in this direction, they're all in this direction, and so it makes it almost impossible to do safe triangulation and to really grab the idea would be to grab the gallbladder here at the infundibulum and lift it out in this direction, and you really can't do that with that. And then here's a different view, so you can see you can compare these two. So everything's sort of collapsed in one location here, and here we're able to. So the assistant's grasping somewhere up here on the fundus. Here's my grasper here in my left hand, and the infundibulum splaying things out, and you can very clearly see. So here's going to be the cystic artery. Here's the cystic duct, and then here's actually the common bile duct down here. You can see it pretty well in this particular case. And you have to remember, when you see videos of it, when you see photos or when you see videos with the robotic surgery, that you're only getting one eye, so you're not getting the 3D view. It looks pretty clear in this photo, but with the head in the console, it's a different experience, definitely. So again, the tips for this, so a couple of things that I've picked up for anyone who's interested in single-site robotic surgery is that they make two different sizes of this cannula. So the curved cannula comes in two sizes. I think it's 250 millimeters and 300 millimeters. They almost always use the 300 millimeter. The 200 millimeters, I think I've used 2 times maybe to this point. And so I would just default to the longer cannula, see if it works. Because what happens as these, I'll go back to this and show you this part, the black part, right over here would be the where the metal cannula ends. And the black part of this instrument is flexible. And so the longer distance you have between where the cannula ends and the tip of the instrument, the more flexing you're getting in this. And so the less flexing, the better, it gives you a little better strength. You can use a long grasper through the 5 millimeter assistant cannula. I'll just set that up. And then the camera, we use a 30-degree camera, so it's at a 30-degree angle, and you can do up and down, and then I can control right and left and moving around and changing the horizon. So we switch back and forth. So when we're first going in, I have the camera looking up so that the assistant can grab the fundus and lift it up. Then we switch it to look down. At that point, then that really focuses in on the cystic duct and the artery. It makes it easier for me to see the clips as they go across the duct and the artery, and then divide that. And then once we've done that, then we switch it back to up because it gives the assistant some mobility again. When it's looking down, it sort of pushes against their retractor and holds them in place. And then we switch it back to up so that then they can move around pretty freely. I can see better, and we can bring it up and dissect it out in that way. So that's pretty much it. Any other questions for me?
Well, excellent presentation, Brian. Thank you very much. You know, I was when I first heard about robotics, it just kind of reminded me of the days of, you probably, I don't know if you were familiar with, when Louis Pasteur first presented his theory of bacteria causing infection. Mm-hmm. He was literally stoned in London. They threw him out. And I imagine, I don't know, I just see this as being, especially among the state community of surgeons, where, you know, they've done things the same way so long, many things, and to have the introduction of a robot in the OR, I imagine, but maybe you weren't around for the end of that, right? You weren't really around when it first came on the scene?
Yeah, there's some of that now. As it catches on more, you know, you have to sort of have to try to figure out what's hype and what's really useful with it. And I think there's a lot of questions. You know, a lot of the questions really are going to come down to, is it cost effective? And I think that's going to be where the challenge is going to lie. I know looking at for us and for our system, for some procedures, I think it probably does make sense, and there are some other procedures where maybe it's not going to pan out.
Right.
Just on a cost basis for the hospitals. For the patient, it doesn't matter. The patient cost is the same. You know, and for the surgeon, it's the same too. But we'll have to see how that pans out.
Yeah, you did touch upon the appendectomy being a procedure. It really wasn't cost effective to do it robotically. What's it like with patient satisfaction? How do the patients feel about it?
Patients like it. I haven't had any issues where people don't want it or where they don't trust it. I know there's been some reports in the press with issues with it, mostly with other fields. But really, especially the single site, it's not always that the patients request it, but once they understand what the option is, anyone that I've ever had for one reason or another with scheduling to change back over to multiport laparoscopic, they're not usually all that happy about it. So I try and keep anyone who's going to be single site.
Do you prepare the patient with videos or just kind of visually explain with an iPad or whatever what exactly is going to happen robotically?
Yeah, I usually just explain it, but if they are interested in it, then either they've looked it up themselves and found it on YouTube, or they can go to our website either through our practice or through my website, and I've got links to videos and whatnot on there, so they can find all that. Plus, there's a lot of information both for patients and for physicians at Intuitive's website also for the Davinci.
Okay, well, this question was tweeted, I think, probably by a surgeon. Uh, he said that in certain types of surgery, like hand surgery, which is done under the microscope, you can see actually tremors of the hand because the microscope obviously picks up more. Is it the same with the robotic? You see it?
It is, yeah. The robot actually will filter out some of the tremors, so it's steadier than. There's a great video. I don't have it, but I'll see if I can find it. I'll try to put a link up somewhere. But there's a pretty amazing video where you can see they have half of the screen is a laparoscopic instrument which is being turned, and the other half is a robotic instrument which is turning. And the robotic instrument is turning sort of like this, and the laparoscopic one is shaking all over the place, and it's just yeah, it does filter out the fine tremors.
Yeah, I can remember scrubbing on hand surgery. I couldn't drink a cup of coffee before scrubbing, before trying to assist, because there was a noticeable difference from the days I drank coffee and didn't drink coffee. You could really see it under the microscope.
Yeah, yeah.
And
And zoomed in that far, you can see it. You can see it with the Davinci, but it does give you some of that filtering, which is nice. Yeah, the other thing, speaking of trimming, the other thing that I didn't mention, but one of the big benefits for the surgeon is just the ergonomics. So instead of standing and leaning over the patient, holding an instrument at some awkward angle with your arm for an hour or two, you're sitting down, and you can position it, position the arms of the everything is ergonomically adjustable, and so it's much less fatigue for the surgeon after a long procedure.
that must especially appeal to the cardiac surgeons because the 8 hour procedures of
Right.
bypass. I don't know what bypass takes nowadays. What's the normal time period of a bypass nowadays?
The bypass, yeah,
6 hours.
I think it's probably somewhere around 4 hours or so.
Oh, 4 hours. Okay, it's decreased since my day. It formerly was like I think around 7 or 8 hours when I was training. That was 20 years ago. Look, a couple more quick questions, Brian.
Okay.
You mentioned the team training. The team kind of has to be up to snuff. Obviously,
Right.
they have to know the instruments. They have to know the technique of robotic surgery. How long would you say would it take a team? Like, you take a team that's totally cold, doesn't know anything about robotics, and you bring them into the OR. How long does it take to train them in the technology of robotics to assist a surgeon effectively?
It's it would take a while. I mean, it really, again, the best possible way to do that would be to train everybody at the same time, and so it takes you know a dozen, probably 20 cases maybe before everyone I think is really up to speed. Uh, just as far as the making it smooth. And then the other thing too is that even once the team is up to speed, it probably takes every time you introduce a new procedure, I think it takes 3, 4, 5 cases to really just get the flow down. Again, every single time, just about when do you put in sutures and which arm is better to use for which particular part. Just things you don't have to think about with laparoscopic surgery. Um, but it definitely takes some time, and the people have to be interested in it. The other thing that helps a lot too is that when you're starting, when you have a good team, I'm at the point, and my team is excellent, and they can, I mean, I can sort of, we just can sort of let it go. It just kind of flows. But early on, for people who are just starting, I think it's a good idea to do some of the they call it callback, and like what the pilots use, where you really need to focus on instrument exchanges and making sure that everybody knows what's going on. And so, since the surgeon can't control that, the assistant has to do it, and the scrub tech has to hand it. So you have to be, instead of just saying, give me the scissors in my right arm. Well, your right arm, especially that's vague. You don't know, is that arm one or is that arm three? Or in single site, it's reversed, and so what seems like the right arm might be the left arm. So it's a good idea to get in the practice of saying, I want a scissor in arm one, and I can tell on my console, and they can look and see it says one, and then they'll exchange it, and they put it in and say, you have scissors in arm one, and then I say, I have scissors in arm one. That's really how you got to do it. Now, I don't, we're pretty smooth at this point. We don't do that, but for new teams that are training, I think that's a good way to go about it.
Very good. You mentioned proctor. I imagine in small hospitals, they have to kind of import a proctor, or does Davinci get involved in getting proctors to that hospital?
That's how they do it at this point. So if it's in a big system where there are people who are already using it, they can sort of proctor their own people. But for smaller places or for new programs, they do have to bring in somebody. And so Intuitive has a system set up for that. So they'll kind of take care of that for them. Hope to get that coordinated.
Very good. Okay, Brian, thank you very much for an excellent presentation. And if we have more questions, I'll let you know. But that's it for tonight's presentation. Thank you very much, and we hope to see you again, Brian. Thank you. And hold on, Brian, I'll talk to you later after we get off the broadcast.
Okay, thank you for having me.